think you've done is remind us that it's not so simple as just to say, okay, now we're going to a single payer. There's like a lot of process involved there and step-by-step calculation about the changes that are necessary, and we'll have a chance to talk about that. Another incredibly important leader in the work that has gone on in Vermont, the groundbreaking work, is Dr. Jim Hester. Dr. Hester was the director of the Healthcare Reform Commission for the Vermont State Legislature and has actually been involved with Vermont for many years in terms of looking at the issues related to improving healthcare access, quality, and focusing on cost. And he's worked for decades now in the field of health and held senior health management positions in Massachusetts and the Pilgrim Healthcare in Boston and Tufts New England Medical Center, as well as Choice Care in Cincinnati, although most of his life has been, or most of his last few decades has been focused in Vermont. Most recently, Dr. Hester was the acting director of the Population Health Models Group at the Innovation Center at the Centers for Healthcare and Medicaid Services in Washington. And that center was established by the Affordable Care Act as a way of improving healthcare. And Dr. Hester was in the lead of thinking about that and thinking about the ways of linking improving population health to larger health populations with, at the same time as clinical care was improved. So I would mention is one final indication that Dr. Hester is brilliant is the fact that he has decided to have a child who is going to Northeastern and who is one of our, just a terrific student. So Dr. Hester is going to talk about some of the specifics involved in the Vermont system, about how you get into the nitty-gritty, roll up your sleeves and think about actually paying for a transition to single payer, as well as improving quality along the way. Dr. Hester.
Yeah, I want to thank John for providing the opportunity for me to have dinner with my daughter, as well as having a chance to speak with you. And thanks for coming out on the evening, which you have many other attractive distractions in Boston. Harry and I worked together for almost 4 years when I was at the Vermont State Legislature. He was a member of the Healthcare Reform Commission. The way that Vermont worked was the legislature meets sort of January through May-ish, for 4 or 5 months a year. And so when the legislature was in session, I served as senior staff to the Health Care Committee in the House and the Health and Welfare Committee in the Senate, which was actually involved in the legislative process. When they were not in session, the commission, the Healthcare Reform Commission, went into effect, and we used that in order to identify opportunities for new legislation and how to develop our strategy and move our strategy along. So I had a chance to work, very intimately with Harry. And really, you've got a sense of his perspective and the wisdom that he brings to this one. I can assure you, he's been at this a lot longer than 2 years. And the time that he's been a commissioner, he was a very active part of the legislative process for a really long time. John mentioned that I've spent the last 2.5 years in Washington. It was an interesting experience. One of the things that came out of the Innovation Center was the State Innovation Models grant that Harry referred to. I think one of the things that's very clear from that experience is the states are where the action are. In terms of healthcare policy, healthcare reform, and the states provide tremendously important laboratories for trying to understand how do we make the system perform better, how do we provide the coverage to our residents in a way that is sustainable. So that the time in Washington renewed my interest in working at the state level to try to achieve results. And Vermont, as Harry described, is an incredibly effective laboratory. It has been a laboratory for change for a variety of reasons. Not just its size, but as I'll talk, the spirit of collaboration. It's in the water, it's in the air there. And there's a whole bunch of mechanisms that we've created so that people, stakeholders that normally would talk each other and work together side by side on collaborative ventures in a variety of ways. And that's been an important part of our being able to do this work and move the agenda forward. So I just want to emphasize that aspect of what's going on. So you're going to find that there's this is a session on the road to single payer, and you're going to find that there's a consistency between Harry's presentation and my presentation, and then you cannot talk about single payer without talking about the broader healthcare reform. So yes, I'm going to walk you through some of the financial issues in the single payer system. The starting point for this is, there's really two perspectives on this. One is, what does it take to start a single payer system? To initiate it, to get it off the ground. And in order to answer that question, as Perry outlined, the goal is one entity that's paying for the healthcare needs of all Vermonters using one payment system. That's where we want to go. So if you want to do that, if you want to put that in place, there's some certain very basic questions that you have to ask. First one is, how much money do we need? All right? What's the pot look like? What are we talking about in terms of the total healthcare expenses for all Vermonters in the state? The second is, all right, where is that money going to come from? Right? How are we going to actually collect it? Right? And the third one is, how will we pay for healthcare services? These questions are connected to each other, they're not independent. How you pay for healthcare services does, as Harry's already pointed out, influence how much you need, where you get the money from, particularly the share that consumers and patients bear, cost sharing money, also influences behavior, influences the amount that you need, influences the care system. So these are fairly basic questions. I'm going to try to walk through them, but I just want to understand there's a complexity here in terms of the understanding the interactions between them. It's not just as straightforward as you can just use a single answer on it. But once you've put it in place, we don't want to put this thing in place and find out 5 years later that we funded it at $7 billion and it's costing us $9 billion, right? That the financing sources that we put in simply aren't adequate for the job. So the hard, and really the most difficult part of the single payer system is making it sustainable over the long haul so that it can survive, so that it in fact can cover the cost. The basic issue in healthcare costs, the reason that it's not affordable is that for decades, the rate of increase, as Harry pointed out, of healthcare expenses, what we pay for healthcare, has consistently outstripped, has consistently been significantly higher than the rate of growth of the revenues that support it. When those revenues are based on payroll taxes or income taxes or whatever it may be, whatever you put in place, yes, it's in balance initially, but over time, it goes out of balance. When I started in the healthcare field in the 1970s, healthcare expenses were less than 10% of gross domestic product, they were about 9%. And people were forecasting doom when it hit 10 or 12. And we're now at 17, running to 20. So that's what's happened in the last 4 decades. Something that is not sustainable. Something's got to give on that. And so I know your interest is primarily in single payer system and how you do that, but I just want to emphasize you cannot put a single payer system in place without addressing the fundamental issues that Harry was talking about in terms of how do you make it sustainable. How do you control, we're talking about transforming the way that our current system performs in order to do two things. This is the famous triple aim, or the three-part aim that it's become sort of a mantra in the system. We want to control the rate of growth of total costs, while we ensure that if you need care, you're going to have a good experience. We've had some experience in this country with trying to go to controlling, just to focus on controlling total cost, putting capitation in place in the 90s, and having some abuses of that because we didn't protect consumers. We didn't pay attention to what's the patient experience going to be. So we recognize that we've got to do it differently this time and when we put it in place. So we say, yeah, control the total cost, but make sure that you're still providing good care to the people who need it. And then the last piece, the third part of that triple aim, is improving the health of the population as a whole. You know, Harry, I can't overemphasize the importance of the last part of Harry's talk on the population health. People who have studied why have costs gone up so fast? What's been the drivers on that? When you're talking about technology and the aging of the population, you have people speculate about what it is. One of the major drivers has been we simply have a lot more chronic illness. If you take a look at the obesity epidemic, and that's the only word to describe what's happened to obesity in this country over the last 3 or 4 decades, you look at the impact of an increased rate of obesity and chronic illness that's associated with the obesity, that's driven by obesity, that explains more than half of the difference of rate of growth of the cost for Medicare, for example. So if you don't control the prevalence of chronic illness, you don't control the factors which are causing disease, we're never going to have a chance to get the total cost under control. So that's why, you know, yes, we're talking about single payer here, but it's a broader story in terms of what do you have to do in order to make that work over time. So let's focus on the issue of starting up, the startup financial issues. So the state retained UMass and a consulting firm to do a number of things, you know, to try to give us the information we need to answer that question. First, they said we wanted to get a baseline on what's happening in 2014. So what's the likely covered population in 2014 by type of coverage for all Vermonters, given the changes that are likely to result from the Affordable Care Act. What's that going to do in terms of how's that going to change the landscape in Vermont? Once you know what the population is, then estimate the likely 2014 cost of coverage for healthcare for all Vermonters. Again, taking into consideration the changes in benefits and the other things that Harry described that are caused by the Affordable Care Act. But then you get to an interesting part, estimate what's going to happen between 2014 and 2017. Again, our milestone for actually starting single payer is 2017. So we've got to say what's going to happen in 3 years and project the world in 2017. And then, so you know, you estimate what the coverage and the costs look like in 2017. Then look at the current distribution of the cost burden of coverage on Vermonters and Vermont employers. Okay, who's paying for what under the current system? How does that play out? You've got to understand what that looks like if you order to understand what you're going to place to replace it. And then you can say, all right, you know, we're going to, knowing what the cost burden on the employer and Vermonters is going to tell us something about what we need to raise, then look at the revenue sources. What are the ways in which the state could raise, the alternative ways in which the state could raise those revenues to fund the single payer system over time, and what are the pros and cons of those different sources. So this was the consultants' work, what they were retained to do, and I'm going to give you the summary, the highlights of the work that they did. If you want more detail on this, there's a healthcare reform website on the Vermont government, and it has a much more detailed presentation, more information than you'd want to know. So that's a resource for if you want to go into that. So. What would the world look like in Vermont in 2017? Total statewide healthcare costs. This includes the Green Mountain Care costs, non-Green Mountain Care costs. You know, it assumes that with reform, all Vermonters have health insurance. With reform, the benefit changes, the benefit package are more comprehensive in the way that Harry described. So in 2017, what this shows is it's showing the total cost without reform. That's the top line going across. If you didn't put the reform in place, And then below that is the total cost with reform, with the changes we're talking about, and additional costs or savings. So if you go across on the table, the number of individuals covered is the same, 636,244 under both cases. The next line is the total paid claims per year. If you put reform in, cover more people, have more richer benefits, the estimate is that we'll pay an additional $87 million for those benefits for goods. So the claims costs will go up by $87 million. The next line over is your administrative cost. One of the benefits of a single payer, as components tout, is it's simpler and cheaper, and it is. So the estimate from the consultants was that we would save $122 million on administrative costs by putting the health reform in place. So what you have is savings of $122 million, additional claim costs of $87 million, which offset each other. So you end up with a net saving of $35 million by putting the single payer system in place. So you have the ability to provide the insurance coverage to all providers, provide the increased benefits, and fund that by the administrative savings of single payer system. All right. Then the consultants took a look and said, well, all right, no, excuse me, this is a little bit more detail on the ways in which we're providing additional value through the enhanced coverage. And I'm not going to go through the detail, but some of the ideas, some of the items are the pediatric dental care, pediatric vision care that Myra was talking about, etc. I will say that one of the things on there is, one of the provisions of the Act was to try to have Medicaid pay a fairer share of the total cost. Medicaid is traditionally not reimbursed or paid providers for the two costs, and that results in a cost shift from the government to employers, so that people are paying for full freight. We wanted to correct that imbalance as part of this and put a policy in place to do that. That doesn't change the total claims cost. That's simply changing who's paying for what's going on and then reallocating. And then the consultants did a projection for the 3 years from 2017 to 2019, doing a similar kind of analysis to the one that I just showed you before. What happens with reform, what happens without reform, the savings from reform. And you can see that the savings in 2017 of $36 million grow each year. They accumulate more savings over a year. Part of that is from, again, savings on the administrative, continuing savings on the administrative costs. But the rate of growth of the medical expenditures was projected as being a little bit lower as well. So it's a combination of the two. But the 3-year total, the single payer system, is again providing all the benefits of a full coverage and enhanced benefit to the population, and still saving $281 million over what it would have been without the single payer system. So it's a pretty nice story in terms of the overall picture of total expenses and the benefits of moving to a single payer system. Now, so that's the total cost. Where does the money, the second question, where does the money come from? What are the sources of revenue? And this is currently we're spending just under $6 billion in Vermont, a small state, on healthcare expenditures. That is divided between the out-of-pocket of $800,000, private insurance a little over $2 billion. So out-of-pocket and private insurance is about $3 billion. Between them, we're about half of the total. Medicare and Medicaid is, the government is the other half of that. So that's where the money is coming from and under the current system. And what we're talking about changing is particularly the individual and employer contributions in that out-of-pocket and private insurance, because how are we going to fund that? The estimate was that The new financing system, again, this is showing the sources of the revenue with reform, without reform, and the difference. And the big difference between the with reform is that the load on individuals and employers decreases, in this case from 2.2 billion to 300 million. It's a decline of almost $2 billion that they're not be putting in anymore, because they're not be paying directly to the insurance companies for their premium benefits. So the other contributions, again, there's the other noticeable change is an increase in the Medicaid, the federal Medicaid match of about $250 million. So that offsets a little bit of the money that you have to raise, but you still have to raise something like $1.6 billion from a state revenue source to offset the contribution from the employers and the private individuals. You're still going to have something coming in from individuals from cost sharing. You want to have some piece of that, so that's why that's there. But $1.6 billion in the state of Vermont, as you'll see, is a significant amount of money. What I want to emphasize, though, is what we're talking about is finding a new funding source, not increasing the total amount of funding. Again, we want to emphasize that the single-payer system will actually cost less on the total cost, but we still have to find a way of finding what that funding source is going to be. So the policy debate needs to focus on redirecting the money that Vermonters already spend, and finding a new way of tapping into that, and paying less to cover more people with more valuable benefits. Now, to give you a sense of the current revenues for the state of Vermont as a whole, these are the revenue income for Vermont from all the sources that it has. Sales and use tax, about $600 million. Income tax is about another $300 million. Property tax is $300 million. All sources of revenue, $1.2 billion. Okay, so what we're talking about, just to put that in perspective, this is a chart. We're talking about the items in red are the healthcare expenditures that we're trying to fund. All right, and it's overall, it's a couple of $1 billion. The blue is what we're currently collecting from those revenues, from the state revenue sources. So the thing that's causing a little bit of political issue here is that we're not talking about tweaking the income tax or tweaking the sales tax in another percent here or something. You're talking about a multiple, doubling it, tripling it in order to find enough money to cover what's happening in it. So one of the dilemmas of the healthcare system is it's so expensive, there's so much money involved, that the state stepping in for a single payer system, it makes a fairly dramatic change in the tax structure. It's not additional money, but there's going to be a perception of the people who are hit by it of a dramatic change. And there's also going to be winners and losers. It's going to be very hard to create a way of tapping into these state revenue sources in a way that replicates the current burden across, because employers vary widely in terms of how much they contribute. Individuals contribute very widely in terms of the amount of coverage and how they have to contribute as well. So that's part of the issue in this, and part of the policy debate is trying to say, how are we going to find a revenue source that imposes a burden which is distributed in what we think is a fair and equitable way, when you're talking about sums of money which are so substantial compared to the current tax burdens and the way they're structured. So some of the considerations in choosing the sources is, what is the ability? Is it the ability to sustain the priorities over time? And what's the rate of growth look like? Is it reasonable? The impact and fairness of financing on individuals. How does the load fall on individuals? The impact on the business and provider communities. We have part of the core goals that Harry outlined is we want to have equity and fairness in terms of how this is, the costs are allocated to the population and employers. So that's a core principle of our value. How do we do that in a way that reflects those values? What's the impact of the revenue sources on wage earner contribution versus non-wage earner contributions? And what's the right mix? And how are these revenue streams going to change behavior and influence behavior? We haven't decided. Okay. All right. We have not decided. I mean, I think that is one of the debates that's going on, within the state, is how, given the story I just laid out for you, how to fund it, how to do it. And that's the cutting edge of the discussion in the state. And I think it will probably be a major topic for the legislature in this next session. So, to be continued. We're on the path, but we have not completed the journey yet. And it's a very important and a very difficult step to go in terms of resolving how actually to fund the single payer system within the state. I hope you have a sense for what's involved in that. So, but once it's in place, second question, sustaining it. And how are we approaching that? I want to sort of elaborate a little bit on some of the points that Harry was talking about. So why delivery system reform? Again, the problem is that the current system has unstable costs and it has variable outcomes, as Harry has explained. So we want to transform the current system to reward those triple aim outcomes that I described earlier. A conceptual model. What does that mean to transform the system? What are we talking about here? Neil Halfon at UCLA has put together what I think is a very compelling and understandable description of the transformation we're talking about. He talks about the progression, the evolution of the healthcare system from healthcare 1.0. We have the web the technology 1, 2, and 3. So acute care, the healthcare 1.0 was the original acute care system. One of the reasons that we're having troubles with the performance of our current system is it was not designed to take care of the kinds of patients that we have at the present time. It really was designed for acute care where you get sick, you go to the doctor, you go to the hospital, he gives you a pill, she does a procedure on you, you get well, and you go away, okay? And then your acute care episode is over. That is a relatively small part of our healthcare demand at the present time. We have a much larger burden and we spend 2/3 to 3/4 of all our expenditures on chronic illnesses that don't go away, that the patient lives with for their entire life. And the way that you manage, and the way that you work with patients to take care of chronic illness as opposed to acute illness is fundamentally different. You don't want to have the doctor sitting there waiting for the diabetic patient to get out of control and come in and show up in the emergency room, or the asthmatic patient to have an episode and be out of control and show up in the emergency room. You want to be proactive in terms of understanding what are the things that need to be done for that patient to manage their care condition more effectively. And the patient plays a much more active role in self-management and self-care. They're seeing the doctor, the healthcare system, 1% of their time in their life. They're living with their illness in their home, in school, at work for 99% of the time. They have a role in this as well. So healthcare 2.0 is really this coordinated care system that's much more responsive to the needs of patients with chronic illnesses as opposed to acute illnesses, and restructures the care system in the way I'm talking about, that works more effectively with patients in managing chronic illness. But there's another step on the journey, which is this healthcare 3.0 on the far right-hand side. This is where we start getting at an integrated health care system which gets at the root causes of chronic illness. It doesn't just provide care for chronic illness. It says, what can we do as a health system to improve the health of the population, reduce the incident of chronic illness in the first place, and get at the drivers of illness in the first place. So it's truly a health system as opposed to a healthcare system. So what we're trying to do is move from 1.0, most of the country is somewhere between 1.0 and 2.0. There are, and a lot of the work that Donia described is sort of moving towards a 2.0 type of system where you have enhanced medical monitoring and whatnot. There are relatively few systems that help the communities that are really on the journey to 3.0 and doing that work. They exist and they're out there, and part of the job is going to sort of expanding on that base and building on that base. So how do you move a delivery system? Something as big as, again, healthcare accounts for 20% of the gross domestic product in the country. It's a huge system with a lot of inertia and a lot of change. So how do you change it? How do you move on? This is the strategy that the Innovation Center I worked with in Medicare and Medicaid came up with. It says, we have to recognize where each health system is and meet them where they are on their journey and provide new tools or new processes or new payment methods that will take them from where they are to the next step. So there's some people who are very early in the journey, who have not done very much, and a simple thing like bundled payment, where you provide a bundled payment for a hip surgery or for a knee surgery, and you have the doctors and the hospitals and the rehab people and whatnot work together on a very narrow set of medical services to understand how can we do it better. That's manageable, that's bite-sized, they can do that. There are other systems that are working under a global budget, under a capitation type of financing for decades. They're much more mature, they're much more sophisticated. They have data systems, they have relationships that have been established between the physician and the hospital. They're further on the right hand. And we had something called the Pioneer Accountable Care Organizations, which was our intervention for those much more mature systems, which moved them along. So the idea is have a portfolio of interventions, a portfolio of changes that you can put on the table, understand the needs of the community that you have to be working with, and move them along. And the measures of success are the ones we talked about with AAA. So this is Vermont. Harry's talked about it already. I'm going to skip over this one. The reform strategy, I'm going to go back one act before Harry's journey to Act 191, which was 2006, created the major themes for reform, which first of all was a sustainable reduction in the uninsured from 10% to 4%. Before the Affordable Care Act, we put something in place which would provide subsidies to Vermonters who were uninsured and had been uninsured for some while to try to reduce the level of insurance. We couldn't do it for everybody, but we could do a partial thing. So that gave us some nice experience on how to do an exchange-like mechanism and provide the subsidy. The other thing we recognized is that there's no way that we could get the performance that we needed out of the healthcare system with key information, clinical information, sitting in paper charts on shelves in physicians' offices and in hospitals. So we started on the journey of health information technology for both creating a state information exchange and providing electronic medical records for primary care physicians using state funds by a 0.2% tax on all claims paid in the state that funded the health technology fund. So before the HITECH Act, before the feds got involved in this, we had a couple of years head start in trying to put a technology platform in place that we were doing. And then the delivery system reform, the showcase element of that was the blueprint for health. What I'll talk about and give you a little better sense of. So how do you build a community health system? How do you transform the delivery system? There's a mantra in systems engineering, and that's my background. My roots are on the engineering side. Every system is perfectly designed to get the results that it gets. Right? Otherwise, it wouldn't get them. Right? If you want to change the outcomes, if you want to change the results, you have to change the system. You have to change the design of the system. And in the case of healthcare, that redesign has to occur at multiple levels. We like to talk about it at 4 levels, where there's the primary care practice level. That's where the rubber hits the roads. That's where the sort of cornerstone of all the other changes. But the primary care practice works within a community setting with other specialists, with the hospital, with what Elliot Fisher has called the neighborhood of the medical home. So there's a community level system as a change as well that you need to address. But if the individual practices and the communities cannot do this work by itself, the state has a key role in providing infrastructure, support, financing, training. They're the ones, for example, that did the health information exchange. You couldn't do that at the local level. So the state has a key role in supporting the change. And then there's federal. The federal government plays is a key player. So those 4 levels of primary care practice, community, state, and federal have to work together in coordination in order to get the outcomes we're looking for. Now, payment reform is important, as it's been emphasized. But I want to say that it's a necessary but not sufficient element of reform. It's not enough just to change how you pay people. You have to give them the capacity to do things differently, and you have to build those capacities in. And that's a big part of the story of the blueprint, is how to create at the primary care level, not just the financial incentive, but the capability to manage chronic illness in a fundamentally different way. The heart of the model is, this is something that was put together in sort of the chronic care model. I'm not going to try to walk you through the entire thing, but the heart of it is the way that you get improved outcomes is by the combination of 2 things. On one side, you have a prepared and a proactive provider team. They're proactive in terms that they're not, waiting for it to be reactive, who walks in the door, but they're proactive in terms of identifying what their patients need. It's also a team. It's not just an individual primary care doctor. The other half of the equation, and the guy who put this together gave equal weight to this, is you also have to have an informed and activated individual patient who is activated in terms of being motivated to provide the self-care, to help take care of himself, and is informed as to what to do. And the whole emphasis of this is, how do you create those 2 elements, informed, activated patients, and prepared and proactive teams? So the blueprint for health, one of the elements was payment reform for primary care. The NCQA is a certification body that accredits medical homes and establishes standards for it. They have a way of scoring a practice and how well they're serving as a medical home. So we use those NCQA criteria. We have people come in and look at the practice and how they're functioning and score them. And based on that score, the practice gets a per patient, per month care management fee, which is completely unrelated to what else they're doing. It's a core payment for the capability of serving as a medical home. To give you a sense of the scale of this, if they're at the top of the scale and you're getting full credit, the practice would get about $50,000 per year per physician. That is serious money in for primary care practices. So if you had a practice with 3 primary care physicians, they would get $150,000 a year in this additional funding for the medical home capability. All right. The second element of it was, in order, even though the practice were putting new things in place, they couldn't provide all of the services and have all the resources that were needed to take care of chronically ill patients. They're small, they just don't have the resources. So we created a community health team that's actually located in the community with the physician practices, so that for primary care physicians that had about 20,000 patients, there would be 5 people, 5 FTEs in the community that would work with the physician in the practice. There'd be a nurse care coordinator, a couple of community health workers, an MSW for mental health, and perhaps some other people. But the flavor of it was a team of people that the practice could refer to and work with to do the follow-up work with these patients. This community health team was also funded by the payers. So we had an all-payer solution, changing the way in which primary care was funded in the state, which had one element which would go to the practice, directly funding for capability, and a second piece creating a new team of resources that they worked with in order to manage the patients. There was also strong information technology support and a community-based prevention plan and assessment that was done as part of the community health team. So this is just a rough, brief summary. This is a bubble chart which covers the same ground. This started as a concept that we piloted in 3 communities, covering about 10% of Vermont's population. We tested it out, worked out some of the kinks, liked what we saw, and a couple of years ago said, let's take it statewide, because we're ready to expand this and scale it up. And so you can see the inflection point. This is the number of FTEs in the community health teams. This gives you a better sense. The red is counties where more than 2/3 of the population is being served by these blueprint enhanced medical homes. So overall in the state, about 80%, 420,000 out of the 600,000 residents are being cared for in enhanced medical homes. So that's very broad distribution through the state. We're very proud about the way that this scaled up. So this is not just an idea, this is something that's been actually put into practice. So phase 2 is taking this to the community health system level. How do you move beyond the primary care practice, involving the specialist, involving the hospital? How do you translate potential savings into real savings? And how do you capture some of those savings and reinvest them locally into your community, into the community for prevention and other services? There are some examples of those community-based models that are some starting points. Around the country, we have a start, but we still have a lot to learn about how do you define a community in the functional term, and how do you create payment models that sustain this over time. And that's sort of part of the cutting edge of this thing is we're creating those new kinds of payment models. So in recapping, to start the single payer system in Vermont, we need about $6 billion, but that's $38 million less than we need otherwise. It'll come primarily from the current Medicare and Medicaid, with $1.6 billion from taxes, which replace the current employer individual contribution. And we're testing new models of payment and care for primary care using value-based payment to replace volume-based systems. And we're on that journey. So that's where we are. I know that you came here primarily focused on the single payer system. I think both Harry and I are pretty consistent. You can't have a healthcare system, a single payer system, and have it be successful unless you address these broader issues, these